Hello students, I'm the OGGuru. Welcome to the channel, and today we are going to discuss the NEET PG 2024 recall session, the first session which was conducted in the morning. I'm so happy, as you could see from the smile of my face, so many messages that sir, your app has really helped us, and each and every MCQ in my exam was from your app. In fact, sir, OBGY overall was very easy for us thanks to your video lectures and thanks to the app. Okay, so I request all the students who are giving all the upcoming examinations, whether it's your INICET or the next year NEET PG, all of you can download the OGGuru app and definitely get in touch with me on this number. I'm personally guiding the students, and lots of offers coming up and discounts also coming up in the upcoming days. Now let us start with the recall session. And yes, this was the MCQ. Kya tha? History of infertility, dysmenorrhea, dyspareunia and laparoscopy image. And I'm so happy. What is our famous mnemonic? DID. Dance India Dance. So Dance India Dance is what, sir? D is dysmenorrhea, D is dyspareunia, and I is infertility. So DID is the typical mnemonic for endometriosis. And as also I have discussed, for endometriosis, laparoscopy is the investigation of choice. And what do we see in a patient of endometriosis? Yes, sir, chocolate cyst. And that was the answer. And you can clearly see chocolate. This is not vanilla ice cream and a chocolate sauce. Okay, yes, but this is the ovary which is filled. And why chocolate? Can I eat that chocolate? No, it is nothing but the altered blood. Blood, when I keep at one place, that reddish color will become brownish, blackish, bluish in color. So this is the chocolate cyst, also called as endometrioma. Okay, so endometrioma, yeah, chocolate cyst is the name of the lesion. The condition is endometriosis, and the mnemonic or the symptoms classical DID, infertility, dysmenorrhea, dyspareunia. Dyspareunia is painful sex, pain during sexual intercourse. Okay, it is deep dyspareunia. Okay, and also what are the other lesions which we see in endometriosis, just as a revision? Yes, sir, fruit salad. Yes or no? Fruit salad का मतलब क्या है कि sir, if this is the uterus, we will not only see the chocolate cyst, we will see all the different colors. Yes, sir, red color lesions, blue color lesions. Okay, blueberry, red raspberry, yes, purple raspberry, all of you. And the famous black gunshot or powder burnt spots. Okay, so all these fruits have not gone in the peritoneal cavity, but we will see all this. And all this we had so happy we discussed in our all the videos, and also on our MCQ discussion videos on the YouTube channel also. Okay, so MCQ was chocolate cyst or endometrioma, and the diagnosis is endometriosis, and this was the image or some similar image was given to all of you. Yes. Next MCQ, prosthetic valve patient is on warfarin and she has reached 36 weeks of gestation. Now what do we do? Yes, so again, I'm so happy. I'm sure all of you must have got this correct. What is the answer? But before that, I give out the answer. So when the patient is not pregnant, what is better? Yes, sir, of course, warfarin is better because it's a tablet. So everyday tablet injection, tablet better, and warfarin is much better anticoagulant compared to heparin. Remember students, so when the patient is not pregnant, we always prefer warfarin. As soon as the patient conceives, we know she is pregnant till the end of 12 weeks in the first trimester. What do we do? Yes, sir, shift to heparin. This MCQ will come in the upcoming exams. Okay, shift to heparin. Why? Because sir, warfarin is teratogenic drug, absolutely contraindicated in pregnancy. Why? Because warfarin से क्या होता है? Yes, Conradi syndrome. Conradi syndrome happens with warfarin. Please keep in mind it's a warfarin toxicity or warfarin embryopathy, in that the problem is with the baby ka cartilage, central nervous system, all the problem we get. Okay, specifically central nervous system and cartilage. Okay, that's affected. Now after 12 weeks are over, from 13 to 36 weeks, patient can go back to warfarin because warfarin is superior. Okay, now is the question, sir, after 36 weeks till labor and delivery, I want the patient to be on heparin. Why? Because sir, warfarin crosses the placenta, heparin does not cross the placenta. So what is the problem? So during delivery, if the patient is on warfarin, then mother also more bleeding. But before that, sir, while the baby is passing through the birth canal, baby can have internal bleeding, bruising. So remember, in and around labor and till the delivery, I want the patient from 36 weeks till she delivers, she should be on heparin. And after delivery, in the postpartum period, it is absolutely fine with breastfeeding to go back to warfarin. So again, clap if you feel happy. Thoko tali, all my students, I'm sure you must be jumping in here. Okay, it is exactly alternate. You do not even have to mug it up. It is WHWHW, alternate. Okay, and therefore what is our answer, dear students? When she has already reached 36 weeks, do I continue warfarin? No sir. Do I continue warfarin and heparin? Again, no sir. Yes sir, switch to low molecular weight heparin is the answer. And basically also stop warfarin. Okay, stop warfarin and switch to low molecular weight heparin. I'm sure all of you, or even heparin, whichever is given, I'm sure all of you must have got this correct. Okay, yes, so please keep this in mind, the alternate WHWHW. Please, I'm sure all of you must have got this correct. Okay, yes. Now patient is having bronchial asthma. Which drug to be avoided? Again, so happy. Yes, oxytocin of course can be given, methergine can also be given, and misoprostol is PG even, again no problem, can be given. Yes, my dear students, carboprost is what? Sir, PGF2 alpha. It is a bronchoconstriction and therefore absolutely contraindicated. All these questions were discussed in my video lectures. Okay, so bronchial asthma patient, and if it's having PPH, PGF2 alpha, absolutely contraindicated because it is a bronchoconstrictor. Bonus MCQ, bonus extra knowledge. Anybody? Methergine. Methergine I will avoid in which condition? Next year. Okay. Yes, sir. Methergine absolutely contraindicated in heart disease patient. So as I said, I'm giving extra information for all the students. Even if you're new students preparing for the upcoming examination, you will benefit. Okay. Heart disease patients and hypertensive patients like pre-eclampsia, eclampsia, we will absolutely avoid methergine. Okay, so absolute contraindication for methergine. So read the question correctly. Methergine is same as methyl ergometrin. Okay, so the question is which drug should be avoided or not to be used. Sir, carboprost cannot be used because it's a PGF2 alpha. Okay, I hope all of you have got this correct. Okay, so all those who, if you haven't yet subscribed to the YouTube channel, please hit the subscribe button and do share this video with all your friends and colleagues also. Okay, now yes, again from the history, it's very simple. Okay, patient ko primary amenorrhea, short stature, and of course some more extra features like shield shaped chest or wide carrying angle, all that was given, and all of you know, and this picture was given, and we know primary amenorrhea, short stature, shield shaped chest. Okay, flat chest. Okay, shield chest is seen with Turner. And again, if you look at the karyotype, 45 he hai, 1 is missing. Yes, see, there's nothing over here. So this is our 45XO. Okay, so 45XO was asked, and the diagnosis is Turner syndrome. Okay, Turner syndrome because of primary amenorrhea and short stature, shield shaped chest, widely spaced this. And yes, now very important. Can anybody tell me? And so 45XO. Okay, can anybody tell me Turner syndrome, is the uterus present, is the uterus absent? ये भी बहुत important information है. Do not make a mistake. So Turner syndrome, sir, streak ovaries. Okay, very good. All of you know, okay, sir, streak ovaries. Ovaries replaced by fibrous bands. Basically, there is just streak ovaries. And therefore, anybody, uterus present or absent? Type in the chat box and comment. Yes, please understand, okay, sir, Turner syndrome, uterus is not absent. Uterus is not absent in Turner syndrome. Turner syndrome में uterus होता है but चिंटू uterus. Yes, hypoplastic uterus or a rudimentary uterus. Why? Because sir, uterus requires estrogen for its growth, and estrogen comes from the ovary, which is not present over here, isn't it? Because streak ovaries replaced by fibrous band. So please understand this, student. Keep in mind that in Turner's syndrome, it is not absent uterus. Okay, Turner's syndrome is not absent uterus. Very important take home message. But it is uterus is, yes, hypoplastic or rudimentary or small chintu uterus. Okay, hypoplastic uterus. So this is extremely important information. Keep in mind. Yes, again, very important that when a patient is having hyperthyroidism, which drug I will safely use. So anybody, what is the problem with methimazole and carbimazole in the first trimester? Again, a pharmac MCQ. Okay, yes sir. What is our trick? CA. क्या प्रॉब्लम करेगा मेथिमazole कार्बिमazole स्पेसिफिकली इफ इज यूज्ड इन द फर्स्ट ट्राइमेस्टर? यस सर, CA मतलब one is choanal atresia and second cutis aplasia. ठोको ताली, cutis aplasia also called as aplasia cutis. कैसे भी बोल सकते हैं. It means that few places on the skin there's absence of skin development, like specifically on the scalp and skin. Okay, so propyl thiouracil is the drug of choice for hyperthyroidism, specifically in the first trimester and even in pregnancy. Okay, so PTU is the answer, propyl thiouracil, because which drug can be used or which drug should be used? So remember, methimazole, carbimazole should be avoided. Why? What is the reason? They will cross the placenta and cause choanal atresia in the baby and cutis aplasia in the baby, and of course fetal also they will cross the placenta, so fetal hypothyroidism. Okay, baby ko hypothyroidism bhi hoga because both these can cross the placenta, so both these drugs should not be given to the patient, specifically in the first trimester. Okay, moving on. Yes, again I had specifically told in my lecture कि खाली ये staging by heart करके जाना. Very popular MCQ. This question was regularly coming in 2016, 17, 18. Okay, then last 3-4 years this question had not come. And if you go and see my reel also which I had made, I said कि cancer wise treatment कर लेना, and cancer staging specifically I told कि just remember this कि cervical cancer, most of the time the MCQ, the most famous, cervical cancer spreads laterally. Okay, cervical cancer will spread laterally and it will engulf the ureter, giving rise to hydroureter, hydronephrosis, and non-functioning kidney. This is stage 3B. Okay, so 3B is the answer, and that is why also what is the most common cause of death in patients of cervical cancer? One more MCQ. Yes sir, यूरेमिया और रीनल फेलियर. कैसे होगा यूरेमिया? यस सर, 3B से होगा यूरेमिया. यूरेमिया is the most common cause of death in patients of cervical cancer. Okay, and this is with stage 3B. So you just have to mug up. Cancer cervix will spread to lateral wall, engulf the ureter, giving rise to hydronephrosis, hydroureter, non-functioning kidney. That is stage 3B. Okay, so I hope all of you must have got this correct. Yes, again, recent advances in MTP, the MTP Act, that a sexual assault victim has come. Now she is 22 weeks. So please understand, all of us know that MTP was allowed till 20 weeks of gestation, and the government has made the changes to allow it to 24 weeks. Now, which all cases? 20 to 24 weeks जो agreement हुआ, the allow हुआ है, is for, yes, it's a specifically for rape and sexual assault victim. So of course if there is a rape victim, and second is any fetal, because many times we were detecting the anomalies late. Okay, sometimes the baby has a problem, fetal anomaly, structural anomaly, or sometimes even chromosomal anomaly. Okay, so that problem if we detect late, then now till 24 weeks MTP can be done, specifically for fetal anomaly, chromosomal problem in the baby. Of course, mother's life is at risk. So all these cases and rape and sexual assault victim, this is allowed till now 24 weeks. Exception is what I had discussed it. Yes, sir. Exception is failure of contraception. Okay, failure of contraception के लिए it is still only up to 20 weeks only. So failure of contraception is still up to 20 weeks. So please keep this in mind, because if the condom has torn or if the OC pills patient has missed and if your contraception has failed, you can't be sitting at home till 24 weeks. Okay, so failure of contraception only 20 weeks tak hai. Rape, sexual assault victim, fetal anomalies, chromosomal problem, and one more thing, which is that suppose some special circumstances they have given, like there's a divorce in pregnancy, during pregnancy, suppose a couple undergoes divorce, all these special circumstances also the government, the rules are allowed till 24 weeks. So here it is because sexual assault, it is not that MTP cannot be done. Yes, sir, MTP can be done. Okay, if the question was failure of contraception, separate MCQ, okay, कि a married couple or unmarried couple, this failure of contraception agar hai, which came in the previous year's paper, and there is patient is 22 weeks, then MTP cannot be done. Okay, and all of us know, yes, when we cross 20 weeks, opinion of 2 doctors. Okay, so up to 20 weeks, one doctor opinion is enough. But after 20 weeks, when the pregnancy is more than 20 weeks, 2 doctor opinion has to be taken. So third option is also wrong. Opinion of 1 doctor, opinion of 2 doctors have to be taken. Okay, but yes, MTP can be done. Next, yes, PPIUCD, the government is promoting this program. I'm sure all of you, even in PSM, they must have told you, this is postpartum IUCD insertion. How early can be done? Immediately after delivery. That means, sir, while I'm suturing the episiotomy, after suturing episiotomy, I can put the copper T. Or if suppose, sir, we are doing a C-section, even on OT table, I can put the IUCD and close the uterus. So, but earliest within 48 hours. The question is earliest, okay? So, PPIUCD, why government is now promoting this? Because, sir, if you send the patient back home, the patient never comes back for follow-up, and then they come back pregnant to us. That's the problem with India population, okay? So, within 48 hours, we do it. After that, we don't do because of the risk of infection. And if after that, then yes, then after 6 weeks, okay, after 6 weeks, when the uterus involution is over, and after 6 weeks is again a very good time to put the copper T, okay, or IUCD can be inserted. But since the question was earliest kab kar sakte hain, within 48 hours, that is the PPIUCD. What is PPIUCD? Postpartum, okay, PPIUCD program, postpartum IUCD insertion can be done. Okay, yes. Now this was again a slightly tricky question. I'm very happy that in my video lectures, in my master class, I've discussed this grid staging. Okay, so something like this was given to the students. Of course, this part of the diagram was not given. Okay, and something like this, a grid was given, and this is, they have just asked that this kind of staging or classification is used for which condition. That's it. Various conditions names were given, and this is our POPQ, pelvic organ prolapse quantification. I repeat, pelvic organ prolapse quantification. So yes, a Virgin MCQ came for the first time, quantification, and therefore the answer is, it is used for which condition? Yes, sir, prolapse. So the answer is, it is used for prolapse, which is the answer over here. POPQ classification is used for pelvic organ prolapse quantification. Remember this in mind. Next year, surely the MCQ is coming that, sir, when we are using POPQ classification, what is the reference point? So remember, my dear students, hymen is the reference point. Just keep this in mind. Details you are not supposed to remember. Hymen is the reference point. Next year question surely coming. And when POPQ is used, hymen is the reference point. Okay. So please keep this point in mind. Yes. Now student told me, sir, 4 types of pelvises or images were shown, and in that, remember that like one was a android pelvis. Android pelvis is like a heart-shaped pelvis, android pelvis. Next was, of course, a gynaecoid or a roomy pelvis. Okay, then was a anterior posterior oval, which is the anthropoid pelvis. Okay, and last is a transverse oval. This is a least common variety, platypaloid pelvis. Okay, so platypaloid pelvis, heart shaped or a inverted triangle. Okay, android pelvis, it's also heart shaped or like a inverted triangle. Okay, because the walls are convergent, spine is prominent. This is the android pelvis. Okay, gynecoid is of course a roomy normal female pelvis, and this is the anthropoid, anterior posterior. Now question क्या था, फेस टू प्यूबिस डिलीवरी. सो हैप्पी, सिखाया था हमने कि फेस टू प्यूबिस डिलीवरी इज एसोसिएटेड विथ, सो एंड्रॉयड पेल्विस में होता है DTA, डीप ट्रांसवर्स अरेस्ट. डीप ट्रांसवर्स अरेस्ट इज अ कॉम्प्लिकेशन ऑफ एंड्रॉयड पेल्विस. ओके, platypaloid pelvis is associated with face presentation, face as the presenting part. Okay, face presentation. Okay, and anthropoid pelvis is the answer, which is more favorable or suitable for face to pubis delivery, which we see in bang occipito posterior. Okay, in occipito, face to pubis delivery happens in occipito posterior, and the occiput is at 6 o'clock. So I request all of you, please go back and see the malposition lecture in detail. All these different kinds of DTA and face to pubis delivery, all I have explained in detail. But I remember, but I repeat, face to pubis delivery is with anthropoid pelvis. So this is the answer. It will be an anterior posterior. Now just one thing, please don't confuse this face presentation with face to pubis delivery. Okay, please understand the difference. Okay, sir, in face delivery, face is the presenting part. That means all of you pay attention. This is the eyes, this is the nose, this is the mouth, mentum and malar. So this is your face presentation. Face presentation का मतलब क्या है कि sir, face is the PP, presenting part. That means when I do the PV examination, I will feel the baby's malar, mentum, nose, mouth. My finger will go in the baby's mouth. Baby starts sucking my finger. ऐसा MCQ आएगा कि somebody, when the doctor does a PV, somebody is sucking the doctor's finger. Somebody मतलब baby. So this is the face presentation. Okay, face presentation could be mento anterior or mento posterior. That means what? Okay, sir, this is the pubic symphysis. This is the sacrum. Okay, so when the mentum is towards the sacrum, this is mento posterior face. Okay, this is mento posterior. Mento anterior में क्या होगा? Mento anterior में होगा same thing, only thing the mentum will be now towards the pubic symphysis. Okay, so please keep in mind, okay, in mento anterior, eyes will be here, nose will be here, mouth will be here, and this. Okay, so just look at the mentum. तो ये कहाँ, ये क्या हो गया? Yes, whatever is towards 12 o'clock. Okay, pubic symphysis. Okay, so 12 o'clock पे जो भी होता है, that is what we discuss, and this is the mento anterior. That is not the question over here. Okay, mento anterior, mento posterior. This is the face presentation, which is more common in platypaloid variety of pelvis, is the least common variety. Face to pubis delivery matlab face faces the pubic symphysis. Okay, this is the pubic symphysis and baby ka face. Okay, baby ka face. This is the baby, the hero or the heroine, and the baby will come out from like this. So the face is facing the pubic symphysis. इसको बोलते हैं face to pubis delivery when the occiput is at 6 o'clock. Okay, when the occiput at 6 o'clock, face to pubis delivery happens, and it is a vertex presentation. Face to pubis delivery is a vertex presentation, head delivery. Okay, Yes. Now again, I'm so happy. I said this is a Virgin MCQ, and I was expecting this question to be coming, and therefore it specifically said that this is absolutely PG level. Yes, a difficult MCQ. I said futuristic Virgin MCQ. Where do we apply the vacuum cup? So one thing is that vacuum cup should be applied as close to the posterior fontanelle as possible, as close to the posterior fontanelle as possible. So this is the baby's head, and what happens is, so this is the posterior fontanelle, this is the anterior fontanelle. Line joining the two is the sagittal suture. Now the vacuum cup is a circle. So how do we put the cup in such a way? The answer is that ये आपका vacuum cup है. So you can see we are as close to the posterior fontanelle as possible. Now what is the dictum? Is sir, the center of the cup, okay, the center of the cup should be on the point. इसको क्या बोलते हैं? This clap, if you have learned something new, this is called as the flexion point or the pivot point. Okay, flexion point or the pivot point, and this is 3 centimeter anterior to the posterior fontanelle. So center of the cup should be, they'll confuse and tell you 6 centimeter anterior, 3 centimeter, okay, because remember it's the diameter of the cup is roughly around 6 centimeter. So when this distance is 3 centimeter, the radius, okay, automatically the vacuum cup will be as close to the posterior fontanelle as possible. Okay, so center of the cup, this is the vacuum cup. The vacuum cup should, the center of the cup should be on the point which is called as the pivot point or the flexion point. And where is this point? It is 3 centimeter anterior to the posterior fontanelle, and also by the way it is 6 centimeter posterior from the anterior fontanelle. So posterior fontanelle से 3 centimeter आगे आना है, एंटीरियर से 6 सेंटीमीटर पीछे जाना है, जो पॉइंट मिलेगा उस पे वैक्यूम कप डाल देंगे, सेंटर ऑफ द कप. Okay, so this is a super difficult MCQ and it was discussed in my lectures. I'm so happy, and the answer, I'm sure all of you have learned something new. This is the pivot point or the flexion point. It helps in proper descent and rotation and minimal complications. Okay, yes. Now again, this is a very simple question. Two images were given side by side, and in one में क्या दिया था? First image, both were of the twins. So in first image में the one baby was breech and one baby was vertex. Some student told me, sir, instead of breech शायद transverse दिया था. Fine. Okay, so first was breech or transverse. Some students are telling me whatever, but second was vertex. And second image was given where both the baby were in vertex position, both vertex. Okay, both babies are in. So all of us know. So anybody, कहाँ पे vaginal delivery होगा, कहाँ पे C-section होगा? Sir, when both the babies are in vertex, best thing, of course, here a vaginal delivery is possible, because route of delivery decided by the position or presentation of the first baby. Okay, and when the first baby is non-vertex, why I said it does not matter whether it was transverse or breech. The first baby, a first baby is the one who is coming out first, जो नीचे है, one which I feel on PV. Okay, so what is the dictum? If the first baby is non-vertex, thank you very much, nothing to think, we will go for LSCS, Thoko Tali. So question, whatever it is, I'm sure you must have got it correct. Whether in which vaginal delivery is possible पूछा है. So sir, both vertex or first vertex, I go for vaginal delivery. First baby is breech position or transverse lie, then in that means it is non-vertex. First baby non-vertex, we go for LSCS. I hope all of you had got this correct. Okay, before we proceed further, again a request to all of you to download the OGGuru app. Get in touch with me on the number given. Will guide you which is the most suitable package for you. Masterclass NEET PG, Masterclass FMGE available, which has got everything, detailed theory lectures, MCQ discussion videos, rapid revision notes, my timetable guidance. And also please subscribe to the YouTube channel and follow me on Insta also. Yes. Now again here, what was the image given to all of you? Cystocele, rectocele bhi shayad, I'm not too sure. But this is what students have told me. Okay, sir, this is the uterus, this is the cervix, this is the vaginal opening or the introitus. So when the cervix prolapses into the vagina, this is first degree prolapse. Cervix in the vagina only. When the cervix is at the level of introitus, that is second degree. Of course, fundus hoga. Okay, so uterus is understood. Uterus आप draw करोगे यहाँ पे, uterus आप draw. Okay, when the cervix is outside, so suppose this is the fundus, this is the tip. Okay, so when the cervix is outside, this is third degree, cervix outside is third degree, and whole of the uterus including the fundus. That means, sir, in this, still the fundus is inside, you can see. Okay, fundus is still, but here, sir, this is the situation when the cervix is also outside and the fundus, you can see fundus now, the I'll draw in another color, the blue color. Okay, so fundus, all of you can see, fundus means the whole of the uterus is below this black color. Okay, black is the vaginal opening. Okay, so this is fourth degree prolapse or procedentia. Okay, prolapse of the uterus, even the fundus outside. Surprisingly, prolapse is a rarely asked topic for NEET PG, but today 2 questions came from prolapse. And I'm sure all of you must have got it correct. Okay, so fourth degree prolapse, procedentia, cystocele, rectocele was along with it, also generally present. Then you can mark it that's a cystocele, rectocele, but basically procedentia means complete prolapse or a fourth degree prolapse. So remember that here, sir, you can, all of you can see fundus is inside. Fundus will be inside. Here also fundus inside, fundus inside. So in first, second, third degree prolapse, the fundus is still inside the vagina only, and outside the introitus, that is fourth degree prolapse. Okay, yes. Now again, a patient has come to us. I think 35 weeks दिया था. Okay, 35 weeks. क्लू में क्या था? क्लू में ये था कि patient with previous LSCS. Okay, so previous LSCS is risk factor for what? Okay, and the most important that after delivery the bleeding is not coming under control, and then a image is shown to you in which the placenta is still attached. तो यहाँ पे ही आपको समझ जाना चाहिए कि सर placenta, not only placenta previa abruption, you don't need to remove the uterus as such. The bleeding will come under control. Okay, severe PPH, bleeding is not getting controlled, and therefore hysterectomy is done. And what is the risk factor? 2 words, previous LSCS and placenta is still attached, that is placenta accreta. Okay, placenta accreta, it could be percreta, increta. So placenta accreta, the placenta is adherent to the lower uterine segment into the muscle wall. Okay, placenta is, there is no plane of cleavage, so placenta will not detach easily, and it's a condition where it's going to be torrential. If you try to remove the placenta, it's going to be torrential bleeding. So placenta accreta, placenta is directly adherent onto the myometrium scar. Increta, invading into the myometrium, and sometimes the placenta will even grow out, and that is placenta percreta. Okay, so accreta, the placenta is only till here. Accreta, increta, it is invading into the myometrium, and percreta, yes, this was a difficult MCQ PG level, but as this was asked. Okay, so placenta accreta, 2 things why most important risk factor is previous LSCS. So remember, my dear students, when we have a combination, ये combo याद रखना है कि sir previous LSCS plus when it's a placenta previa, is a very dangerous combination. Remember, when I have a patient of previous LSCS and placenta previa, antenatally also rule out placenta accreta. We are supposed to do a color Doppler and sonography, sometimes even MRI, to rule out placenta. So remember, whenever I have a patient, when I have got a previous LSCS history and now the placenta is low lying, not moving up, I always need to do what? Sir, you need to rule out placenta accreta. Okay, rule out placenta accreta on ultrasonography and color Doppler. There are different guidelines and criteria for that because of previous LSCS. And इसमें भी क्या important point है, sir, as the number of LSCS increase, it means with previous 1 LSCS, placenta accreta, previous 2, previous 3, previous 4. As the number of LSCS increase, the chance of placenta accreta also increases. Thoko tali, clap if you have learned something new. Futuristic MCQ. So whenever I've got previous 2 LSCS, previous 3 LSCS with a placenta previa combination, very dangerous. Please rule out placenta accreta because there is a torrential bleeding chances, and most of the time hysterectomy would be required. Placenta attached to the uterus, that is placenta accreta. Okay, now they were last 2-3 questions which I have not got the exact thing, but I know the answer, but I don't need the exact options, and all of you can correct me if I'm wrong. One was the question of magnesium sulfate toxicity. So when do you stop giving magnesium sulfate? When do we stop giving magnesium sulfate? That was the question. Visual disturbances, no, we can continue. The question में clearly student told me कि sir deep tendon reflexes was present. Yes, so knee jerk should be absent, because if the knee jerks are absent, then I will stop the max self. Okay, because knee jerks absent is one of the sign of magnesium sulfate toxicity. So magnesium sulfate toxicity, लेकिन clearly students told me कि sir deep tendon reflex was present. Yes, what was it? Urine output कितना बताया था बच्चा लोग? 25 to 30 cc per hour. 25 to 30 cc per hour. That means when we take the urine after 4, because max self is given at an interval of every 4 hours. Okay, we will give magnesium sulfate 1, and then after 4 hours we will give another dose. Okay, another dose of magnesium sulfate would be given. So at least the urine should be 100 cc. 100 cc urine output होना चाहिए between 2 doses of max self. And in the question paper, student told me कि sir the urine output was given was some 60 cc in 4 hours. So if only 60 cc is there in 4 hours, at just 15 cc per hour, and that is the time when I will definitely stop magnesium. Okay, I hope you have got it correct. Question ये था कि which condition will I stop magnesium or don't give magnesium sulfate? If the knee jerks are absent, I will stop, because the toxicity is happening, respiratory distress, cardiac arrest can happen, and when the urine output should be at least 25 to 30 cc per hour, so at least it should be 100 cc. Remember, it should be 100 cc, 100 ml. Okay, it should be at least 100 ml in 4 hours time, at least. Okay, now next, here 2 things were there. Question was amenorrhea patient. If they had asked absent uterus, okay, so this is like I will give you both the answers, whatever it is you can decide for yourself, I'm fine. Okay, amenorrhea patient diya tha. If it is absent uterus, okay, either way the answer will remain the same. If the question was कि patient is having primary amenorrhea, absent uterus, and normal breast and pubic hair development, normal pubic hair development, then that is what? Yes sir, in this is RMKH, because in Rokitansky, Mayer, Kushner-Hauser or Mullerian agenesis, we get absent uterus but normal axillary and pubic hair. Okay, normal of axillary and pubic hair is normal. So many times in my even the rapid revision video marathon session we have discussed this. So here the karyotype was asked, and the karyotype is 46XX. Yes. What is the other thing that when it is absent uterus? Yes sir, if the axillary and pubic hair is absent, then it becomes the patient of androgen insensitivity syndrome, and then the answer is 46XY. Okay, but so keep in mind the question was normal hair and pubic hair development, तो 46XX ही होगा. And some student told me कि sir they had said कि no absent uterus, so अगर absent uterus है तो ये आंसर है. Okay, अगर absent uterus है तो ये आंसर है. But अगर एब्सेंट यूट्रस नहीं भी है, अगर एब्सेंट यूट्रस नहीं भी है, then the question was that, sir, if a imperforate hymen, so I'm not too sure whether imperforate hymen was shown to you. Imperforate hymen patient will have normal uterus and normal ovary. ये दोनों दिया था, yes. Still the answer is the same, karyotyping, because it's a normal uterus, normal ovary, तो 46XX. So imperforate hymen भी है, या RMKH या Muller Nuggets is there, karyotype will be normal, it is 46XX. So whatever may be the question, answer will be the same, 46XX. अगर आपको absent uterus दिया है and axillary and pubic hair भी absent है, then it is androgen insensitivity, then it is 46XY. Okay, so I hope it is absolutely clear. So whether this, that's why I written over a query, whether imperforate hymen was mentioned or not, no problem, but imperforate hymen will have normal uterus, normal ovary and 46XX. Or primary amenorrhea, absent uterus, normal breast and axial pubic hair, again 46XX. And the last, very important, again I am so happy, double withdrawal negative, E plus P is negative. Now E plus P negative का मतलब क्या है कि sir, first we give progesterone challenge test, we give progesterone to the patient, and if with progesterone the patient gets menses, that means what is the rule? कि sir, progesterone acts only on estrogen primed endometrium. I repeat, progesterone acts only on estrogen primed endometrium. So when the patient gets periods with only progesterone, you need to rule out pregnancy first. Okay, rule out pregnancy. And when the patient get menses, it means estrogen was present, progesterone was absent. And that condition is anovulation or PCOS. And that's why patients of PCOS or anovulation will have progesterone withdrawal bleeding, because estrogen present, progesterone absent. That situation you get over here, because progesterone acts only on estrogen primed endometrium. But when there is no menses, when sir there is no menses with progesterone, when there is no menses, then we give double challenge. We give double challenge E plus P. And double challenge means what? कि सर हमने estrogen भी दिया, estrogen to grow the lining, progesterone to shed off the lining. So अगर double challenge भी negative है, okay, double challenge is negative means what? कि sir it is end organ failure, end organ failure और Asherman syndrome. कि सर यूट्रस के अंदर इतना फाइब्रोसिस है, इतना कचरा, इतना एडिशंस है कि it is either all the end receptors are damaged or there's complete fibrosis inside the uterus. So when the double challenge is negative, it is end organ failure, because the end product E plus P cannot work. So Asherman syndrome, but students clearly told me that sir, Asherman syndrome was not in the option. Sarcoidosis and yes, tuberculosis. So my dear student, genital tuberculosis of course will lead to Asherman syndrome and intrauterine adhesions. Asherman syndrome is excessive curettage or genital TB. So therefore genital tuberculosis should be the answer, because E plus P negative can also happen in severe genital tuberculosis leading to complete fibrosis and adhesions inside the uterus. That are the only two conditions, end organ failure and Asherman syndrome, or tuberculosis, complete genital tuberculosis, where the uterus endometrium is damaged, that will cause E plus P to be negative. That means, sir, in spite of giving estrogen, progesterone, there is no menses. E plus P ke baad bhi there is no menses. And one more condition, absolutely PG level, E plus P negative can also happen. In which other condition? Yes, sir. Suppose it is any outflow obstruction. Okay. Suppose it is imperforate hymen or a transverse vaginal septum, then in that cases also the E plus P is negative. Okay, I hope you understood why. Because sir, the menses will come out, menses will start, but they will not come out because of cryptomenorrhea. Yes, so hidden. So it is actually falsely negative E plus P, absolute PG level. Don't panic. Okay, cryptomenorrhea जो condition है, cryptomenorrhea में it is falsely negative. Why I am saying falsely negative? Because sir, the doctor will not see any blood coming out, so he will say negative, but actually the bleeding is happening. Okay, so falsely negative E plus P, absolute PG level, that is in cryptomenorrhea. But remember this, what is there? Okay, sir, E plus P withdrawal negative is seen with Asherman's syndrome. Yes, I know Asherman was not in the option, but student told me said tuberculosis was in the option, and therefore in tuberculosis, yes, we can get the Asherman syndrome or intrauterine adhesions. Okay, students, so this was the recall session, and all of you, please do not forget to download the OGGuru app and get in touch with me on the phone and WhatsApp number. I'll be guiding you. And from tomorrow onwards, the Independence Day sale is also coming up. So we are giving at a highly discounted price. 3 months, 6 months, and 12 months packages available. These are the complete master class. This includes everything. This has got all the theory classes, all the rapid revision MCQs, all image based question, clinical cases, including beautiful handwritten notes to read in the app, and of course my timetable guidance and the mock test. So masterclass, depending if you're preparing for the INICET, just go for the 3 months package because exam will be in November. If your exam is next year, all of you can go for the 12 months package also, starting from this August till next August. Hopefully the next exam should be in the month of March. There'll be not much delay in the next examination. Okay, so I wish all of you best of luck. Second session recall also will try to come out as soon as possible. And bye bye, best of luck, and thank you very much.